We described the life cycle of hepatitis C virus and looked at the mechanism of action of direct-acting antiviral agents. Now the next learning objective is given a patient with chronic hep C virus, recommend AASLD-IDSA guideline-concordant first-line therapy.
Now here's some reliable resources. So American Association for the Study of Liver Diseases, or AASLD, in conjunction with, in collaboration with IDSA, have developed guidelines for, or I should say guidance for hepatitis C, which are freely available, and they are published online because they get updated frequently. In fact, more than once a year they update it, so they are published online. There's also the Hep drug interaction checker. That you can actually, there's also a Hep iChart app that you can download for free, which allows you to check for drug interactions. So here's why, SVR12 is very important. And of course, SVR12 is just a lab value. It's a surrogate marker. So here's why it's important. So cure or SVR12, generally speaking, of course, if somebody achieves SVR12, that's gonna reduce transmission. So if somebody doesn't have the virus in their system, then they're unlikely to transmit it to other people. So that's very important. Another thing is improved clinical outcomes in the patient. And these benefits, clinical outcomes, include hepatic and extrahepatic. So of course, if you cure the Hep C, there will be reduced rate of cirrhosis, reduced rate of decompensation in the liver disease, reduced risk of hepatocellular carcinoma, and reduced need for transplantation. And of course, there are also studies that show that SVR12 can actually reduce all-cause mortality, improve quality of life, reduce malignancy, diabetes, cardiovascular disease, and renal and neurocognitive disease. So, and of course, the all-cause, not only does SVR12 reduce all-cause mortality, the interesting thing is that it reduces liver-related mortality as well as non-liver-related mortality. So it's not all about the liver. It actually reduces non-liver related mortality. So that's why SVR12 is, although it's a surrogate marker, it's a surrogate marker for a very important clinical outcomes. So the guideline says the goal of treatment of Hep C infected person is to reduce all-cause mortality and liver-related health adverse consequences, including end-stage liver disease and hepatocellular carcinoma, by the attachment of SVR. One of the extrahepatic clinical outcomes is actually diabetes, and in diabetic patients is renal disease. So in this study you can see patients who have diabetes and Hep C, and if they're not treated, they are a lot more likely, significantly more likely to have incidence of end-stage renal disease, whereas when you treat them, they are significantly less likely to have end-stage renal disease. So SVR is extremely important for preventing end-stage renal disease in these patients if they have diabetes. And here's some other, so here's the data that shows that, patients who have Hep C, without treatment, here's the likelihood that, over the years, the all-cause mortality increases, and you can significantly reduce all-cause mortality with simply treating the Hep C. So, the all-cause mortality will be reduced. Liver-related mortality will be reduced significantly, and beyond mortality, if you look at hepatocellular carcinoma, it will also reduce the likelihood of having carcinoma if you actually treat the Hep C. Some important considerations as we learn about these drugs. So, you should pay attention to duration of therapy, because depending on what combination you use and what patient population you're looking at, duration of therapy could be 8 weeks, 12 weeks, or 24 weeks. At the moment, we don't have anything shorter than 8 weeks, but in the future, it's possible to have shorter than 8 weeks. It's also important to know with a specific combination whether you need to add ribavirin or not. So for some patients that are difficult to treat, we actually may need to add ribavirin in addition to those direct acting agents. Another important issue is cost. These, more and more drugs are coming to the market, but every time a drug comes to the market, it's very expensive. So it's important to also consider cost, and also consider difficult to treat characteristics in patients. So generally speaking, patients who do not have cirrhosis are easier to treat compared to patients who have cirrhosis. And patients who are treatment naive, meaning they've never been treated before, they are easier to treat than people who were treated in the past and they failed treatment. So treatment experience doesn't necessarily mean someone who got treated and then they got infected again. So treatment experience means if they got treated and the treatment didn't work. And generally speaking, genotype 1b is easier to treat compared to genotype 1a, and overall genotype 3 is hardest to treat compared to all genotypes. And sometimes, depending on the combination regimen that you use, the black race can also make a difference. So an example would be ledipasvir Sofosbuvir combination, which I will talk about in a little bit. Now let's take a look at treatment for genotype 1 in treatment-naive patients. So in this topic, I will focus on treatment-naive patients. So don't worry about treatment-experienced patients because treating someone who has failed treatment in the past is more complicated, and it's really a specialty thing. So just focus on someone who's never been treated before and they're getting treated for the first time. Sofosbuvir-velpatasvir-voxilaprevir is not indicated for treatment-naive patients because this is our big gun. So we're actually reserving. It's not that it doesn't work for these patients. We're just going to reserve it for people who fail other regimens because this is very potent. And if someone fails any of the other options, they will likely respond to this regimen. So for that reason, the guideline has actually is not recommending it for anybody who is treatment-naive, because we want to save it for people who fail treatment. So a lot of these agents, at some point they were first line. As we get more and more options, so the guideline kind of makes the best ones first line, and anything that's not as good alternative. And by good, I mean whether it's a complicated regimen or whether it's not as efficacious as our first line, or if there's a lot of too many drug interactions. So really, for someone who does not have cirrhosis and has genotype 1a, we really have 4 options as first line. So it's either Harvoni, or Glecaprevir, or Epclusa, or Mavyret. So someone who does not have cirrhosis is easier to treat. So for patients who have no cirrhosis, we actually have 2 options that you can actually do for 8 weeks. So Mavyret, you can actually treat someone who does not have cirrhosis for 8 weeks. And with Harvoni, you can actually do 8 weeks as long as they have a viral load less than 6 million. And they are non-black and they are not co-infected with HIV. So you can for those patients you can do 8 weeks of Harvoni or 8 weeks of Mavyret. Otherwise, you can do 12 weeks of Sofosbuvir-velpatasvir and Elbasvir-grazoprevir. Anything else is not first line. Now, for someone who has compensated cirrhosis, you have to do 12 weeks of Harvoni, or 12 weeks of Grazoprevir, Elbasvir, or 12 weeks of Sofosbuvir-velpatasvir, or 12 weeks of Mavyret. One thing about Glecaprevir is that for genotype 1a specifically, you have to check a NS5A RAS at baseline, and you have to do 12 weeks only if that test is negative. Otherwise, if it's positive, you have to do 16 weeks, and because of that, it will be alternative regimen for those patients. And that's because if you have regimens that are available for 12 weeks, why would you use something that you have to use for 16 weeks? Now, for patients who have decompensated cirrhosis, you really have only 3 options. So the 3 options are, Harvoni with the addition of ribavirin for 12 weeks, or Sofosbuvir-ledipasvir for 12 weeks with the addition of ribavirin, or Sofosbuvir-velpatasvir for 12 weeks with the addition of ribavirin. Now, if for some reason someone cannot tolerate, or if they're ineligible to get ribavirin, then you give the regimen without ribavirin. Well, you extend the duration to 24 weeks. So, for example, if someone is pregnant, so ribavirin is category X, so obviously that person will not be able to do ribavirin, and then you extend the duration of treatment to 24 weeks with any of these 3 regimens. Another thing is ribavirin causes hemolytic anemia, so it's actually dose adjusted based on renal function and also based on hemoglobin level. So if someone has coagulopathy or bleeding issues, then they will not be able to use ribavirin. So that's another reason to not use ribavirin and extend duration of treatment, which can be an issue in decompensated cirrhosis. So if someone has decompensated cirrhosis and they have gastroesophageal variceal bleeding, so if someone is bleeding, then it's not a good idea to give them ribavirin because of the risk of hemolytic anemia. And of course, the 4th category is people with GFR less than 30, including hemodialysis. So up until recently, we only had Glecaprevir as an option, and now we actually have Mavyret as an option too. Now, the only difference is that so Mavyret works for all genotypes, but Glecaprevir is only active against genotype 1. So it's an option for genotype 1 in in dialysis patients, but beyond genotype 1, your only option is really Mavyret or Glecaprevir, pibrentasvir. Now, when you look at genotype 1b, for the most part, genotype 1a and 1b are identical except for 2 regimens. So when it comes to Pro-D and when it comes to Glecaprevir is when it matters whether it's genotype 1a or 1b. For the rest of the regimens, the recommendations are identical between genotype 1a and 1b. So let's take a look. So with 3D regimen or Pro-D, genotype 1b is easier to treat than genotype 1a. So for that reason, you do not need to add ribavirin to Pro-D for genotype 1b, whereas for genotype 1a, it needs to be accompanied with ribavirin. And regardless of whether it's genotype 1a or 1b, it's not first-line recommendation anyway, because this is a complicated regimen. So they used to be first-line; they are no longer first-line. The other thing is Glecaprevir. For genotype 1a, you actually need to check NS5A RAS at baseline, whereas for genotype 1b, you do not. So this resistant associated substitution only happens in genotype 1a. So if someone has genotype 1b, this test is not necessary. So that's really the only difference between genotype 1a and 1b. Let's take a look at specific combinations. Ledipasvir is a NS5A inhibitor. Fortunately, these 2 agents are made by the same manufacturer, so they actually come in 1 pill. So they come in 1 pill, so they're easier to take. So Sofosbuvir is a NS5B inhibitor, and one thing about Sofosbuvir is that 80% is actually cleared by the kidneys. So it's important to have renal function in mind. So Sofosbuvir is actually contraindicated if GFR is less than 30, and Ledipasvir also has a low barrier to resistance. So in patients who do not have cirrhosis and who are treatment naive, you can actually use this for 8 weeks if the viral load is less than 6 million. If it's more than 6 million, you have to do 12 weeks. And of course, in compensated cirrhosis, treatment option will be 12 weeks. And then when it comes to decompensated cirrhosis, you add the ribavirin to the patients. And they say low ribavirin, so you will use a lower dose of ribavirin because decompensated cirrhosis, they're more likely to have bleeding complications, and you do 12 weeks. Now, if the bleeding is so much and the patient cannot tolerate the ribavirin, then they're ribavirin ineligible. then you can do it without ribavirin, but you extend duration of treatment to 24 weeks. Let's take a look at the next option. So pibrentasvir is a protease inhibitor. Now this option also comes with ritonavir. Now remember that ritonavir is a HIV protease inhibitor, so it does absolutely nothing to the Hep C. What it does is that it's a pharmacokinetic booster. So because ritonavir is a CYP3A4 inhibitor, it will basically inhibit the metabolism of pibrentasvir, so we will actually need a lower dose of pibrentasvir. So it's really so that's the R in Pro-D. And some people refer to this as the 3D regimen because there are 3 direct acting agents here. So pibrentasvir, elbasvir, and dasabuvir are the 3 direct acting agents against Hep C, and there's a 4th agent, ritonavir, which does nothing to Hep C. It's just boosting pibrentasvir levels. And then elbasvir is the NS5A inhibitor, and dasabuvir is NS5B inhibitor. Now, fortunately, these are made by the same manufacturer. However, they do have food requirements, so they all need to be, taken with food, and they are not renally cleared. However, because for genotype 1A, you actually need to take this with ribavirin, and ribavirin is renally cleared, that kind of, takes it away as something that you would use in end-stage renal disease because you still need ribavirin. So here's how it comes. So the Vicera pack, which was the original formulation, now keep in mind that we actually use ritonavir to use a smaller dose of pibrentasvir. So even then, the pill was so big that they had to break it into 2 pills. So they have to take 2 pills that contains pibrentasvir, elbasvir, and ritonavir, and then dasabuvir is a separate pill that the patients have to take it twice a day. So in the morning they will take 3 pills. So the 2 pills that contains elbasvir, pibrentasvir, and ritonavir, and one of the 2 pills that has dasabuvir, and then at night they take that second dasabuvir. So it's kind of complicated, but it does come in a pack. So the pack makes it easy for the patients to remember. So 1 pack per day. So they take 1 pack per day, and then they come in boxes of 7 packs for 1 week. And depending on how many weeks you want to treat the patient, that's how many boxes you would give the patient. So it's kind of complicated. That's why the guidelines doesn't recommend it as first line anymore. Because if you have 1 pill once a day options, why would you go through all these pills? And it's important to take these with food. And in addition, most people actually have genotype 1A. So if the patient has genotype 1A, you also need a bottle of ribavirin on the side. So this whole thing is not enough. You actually need ribavirin with it. And we actually dose ribavirin based on body weight. So patients who weigh 75 kilos or more is 200 milligram daily in divided doses. So maybe 600 milligram twice a day. So it would be a handful of pills. And if they weigh less than 75 kilos, you would do 1,000 milligram daily in 2 divided doses. So maybe 600 in the morning and 400 in the evening, because you can't really do 500 if it comes in 200 milligram pills or capsules, tablets. It's also available as packs to make it easier for patients to remember when to take it and how many to take. Since they have to take 3. People lose count of how many pills they've been taking. So this is kind of messy. That's why it's not first line. Not to mention that there are drug interactions because of it's boosted. Okay, more recently there's a new formulation. So there's an extended release. So because before you had to take, the dasabuvir, you had to take it 1 in the morning and 1 at night. So this whole thing was messy enough. In addition, you have to take it twice a day. So they try to make it less messy. So you still need to take all this ribavirin, but at least it's just 3 pills just in the once a day with a meal. So it can be in the morning or at night, as long as it's at the same time. So they reduce it from 4 pills to 3 pills. But at least the schedule is nice. So it's just once a day instead of twice a day. However, the ribavirin will remain in divided doses, so they will still have to do AM/PM, so not first line. Another possibility is to combine sofosbuvir with glecaprevir. Now, glecaprevir is an S5A made by a different manufacturer, so you end up giving 2 pills. And this one actually has, pretty much, like Harvoni and Pro-D, they're fixed dosing, so you just tell them how many pills to take. Now, glecaprevir, it actually comes in different pills, so now you actually have to know what dose to give, because it comes in 3 milligrams, 60 milligrams. Some people need the 90 milligram. So the standard dose is to give a 60 milligram. However, because it's metabolized by CYP3A, if the patient happens to be on a strong CYP3A4 inhibitor, you actually need to reduce the dose to 30 milligram. Whereas if they are on moderate inducers of CYP3A, you need to increase the dose to 90 milligram. And if they're on a strong CYP3A inducer, it's actually contraindicated to take this. The next option is the combination of grazoprevir, which is a second generation NS3/4A protease inhibitor, and Elbasvir, which is a second generation NS5A inhibitor. Luckily, it's made by the same manufacturer, so it comes, Merck comes in a pack, so it's 1 pill once a day. It's very convenient. So it is first line. As you can see, it's a lot more convenient than the other regimens we were looking at besides Harvoni. Because they're second generation, they're well tolerated, and they both have a high barrier to resistance. And neither of them are actually renally cleared, so it's actually an option for patients with end-stage renal disease, including hemodialysis. However, it's only active against genotype 1, so if they have anything other than genotype 1, it won't work. So just for genotype 1A and 1B. One thing that made this complicated is that for genotype 1A in the studies, they actually did NS5A RAV testing, or really should. So RAV stands for resistance associated variant. The nomenclature changed to resistant associated substitution, so we call it RAS now. But anyway, because they, in their protocol, they were checking at first at baseline, it made it to the packet to the FDA approved dosing. So now FDA requires that if you're going to use it for genotype 1A, you actually need to check NS5A, and you can use 12 weeks only if it's negative. So if it's positive, you need to add ribavirin and treat for 16 weeks. And because 16 weeks is too long, the guideline says for those patients, it will be alternative. It's not first line anymore. So orange. But if someone takes the test and it's negative, then 12 weeks. Which kind of complicates it because somebody needs to pay for this test. So if you have other options available that don't need a test, but if you were to use this, you need to order this test, and that's extra cost. That kind of backfired on them. They were really just trying to show that, look, every time we found resistance, it actually worked. So because this has a high barrier to resistance, so that's what they were trying to do. But then the FDA requires this testing now. The next option is addition of velpatasvir to sofosbuvir. So velpatasvir is also made by Gilead, so they made it into a single tablet. So sofosbuvir-velpatasvir. The difference between velpatasvir and ledipasvir, which was also made by Gilead, is that velpatasvir is actually second generation NS5A. So ledipasvir is first generation, velpatasvir is second generation. So they're really just keeping up with the competition. So because of its second generation, it actually has a high barrier to resistance. However, sofosbuvir is still there, so it cannot be used in GFR less than 30. So now, one thing that's special about this Epclusa is that it's pan-genotypic. So it covers genotype 1, 2, 3, 4, 5, 6. So it's excellent. It covers everything. And there's data for decompensated cirrhosis. So if someone has decompensated cirrhosis, just add ribavirin and use it for 12 weeks. And if they cannot tolerate ribavirin, just do 24 weeks without ribavirin. And another thing Gilead did was, so they just added a third agent to the previous one. So as good as Epclusa was, so Epclusa is just velpatasvir and sofosbuvir. They actually added a third agent, so it's still Gilead, so it's still 1 pill once a day. So they squeezed in another agent into that single pill. So it's even better than Epclusa, meaning that it can actually be active against viruses that are really resistant to other things. So if someone failed Epclusa, for example, you can give them Vosevi. So, by the way, Voxilaprevir is also second generation. So all three of them have high barrier. So that's why the guideline actually does not recommend this for first line for someone who's never been treated before, because this is a huge weapon. You know, it's a big gun against resistant. So we really want to save this for people who fail other regimens. So Maviret, which is a combination of a second generation protease inhibitor Glecaprevir and a second generation NS5A pibrentasvir. So high barrier to resistance. However, because it doesn't have an NS5B, it's not renal. It doesn't have renal requirement. It does need to be taken with food, but it's not renally cleared. So you can actually use this just like Zapatir in GFR less than 30, including dialysis. Except this one is even better because it covers all genotypes. So it covers genotype 1, 2, 3, 4, 5, 6. So that was genotype 1. Now, genotype 3 is really important because historically genotype 1 was really difficult to treat, and then we came up with a lot of drugs against genotype 1, and not a lot against genotype 3. So genotype 3 is actually the hardest to treat now, and when you compare different genotypes, when you look at the survival, hepatocellular carcinoma-free survival, people with genotype 3 don't do as well compared to genotype. So more people are dying from genotype 3. In other words, it progresses rapidly. So because of that, genotype 3 is really, really important. And we don't have a lot of options. So for genotype 2 and 3, we really have 3 options. So it's either a combination of sofosbuvir with daclotasvir. And really, this combination, it's only first line for people with decompensated cirrhosis. And that's because with decompensated cirrhosis, we really have limited options. So if daclotasvir is an option, it's first line because we really are left with 2 options here. Okay. And outside of decompensated cirrhosis, it's alternative, but we do have 2 options. So Maviret, for example, is actually contraindicated in decompensated cirrhosis. So if it's not renally cleared, it needs to be cleared somewhere, some way. So it's, it depends on hepatic clearance. So if someone's kidney is, liver is, in decompensated cirrhosis, it's contraindicated to use Maviret. Whereas if someone has end-stage renal disease, Maviret is your only option. It's the only thing left if someone has genotype 2 or 3. And keep in mind that this option was not available a year ago. So a year ago, for someone with end-stage renal disease and genotype 2 or 3, we had to use PEG interferon.